Good afternoon and welcome. Feel free to say hi on the chat so folks know who you are, and feel free to introduce yourself not just to the panelists, but the attendees, so other folks might want to connect with you in the future. My name is Sarah Norman. I direct Healthy Homes and Communities here at NeighborWorks America, and I'd like to thank you for joining our Aging in Community webinar, co-hosted by AHC of Greater Baltimore. Today we'll explore research and applications of aging in community programs, but before we jump in, I wanted to walk through some logistics for how to operate a Zoom webinar. Okay, if you want to share an ID with all the attendees, use chat to make comments or respond to questions that we may ask you during the webinar. You can use chat. To use the chat feature, click on the chat control. The chat box will open up. Type in your comments here, then press enter to submit your response. You have the option to chat with all attendees or with panelists only. We ask if you're comfortable to chat with all attendees so that the other panelists can see the ideas that you're sharing. You can also chat in a Zoom webinar, and so that's the chat, and we'll go from there. There we go. So I wanted to introduce you to our speakers. I'm going to introduce you to Allison Pendle-Jones. Hey, Allison.
Hi, everyone. I'm Allison, and I'm the Assistant Director of Resident Services at AHC Greater Baltimore, which is an affordable housing developer in Baltimore. I'll be moderating the webinar with Sarah. And today we're going to hear from Annabelle Jouard, who's a graduate student in public policy at the University of Michigan. She's been interning here at AHC this summer. Also joining us is Eileen Peltier. She's the Executive Director of Downstreet Housing and Community Development. And finally, Latrice Good, who's the Resident Services Manager at AHC Greater Baltimore Senior Property, Monte Verde. So before we get too far into it, I want to start with a quick definition of aging in community. From the Center for Disease Control and Prevention, aging in community is defined as the ability to live in one's own home and community safely, independently, and comfortably, regardless of age, income, or ability level. Annabelle has spent her summer internship at AHC researching aging in community efforts, so I'll first turn the mic over to her to talk about her findings so far. Annabelle.
Thank you and hello. So I've been working on a report surveying NeighborWorks networks organizations, aging and community programs to help others within the community development field learn more about what can be done and how to frame their own initiatives.
Annabelle, can you walk us through what an aging and community program, what you've seen so far?
Yes. So programs vary widely within the aging and community space based on both the resources available and the actual needs of each community. I think of it as addressing social determinants of health with a focus on empowering seniors to continue to live independently as long as possible.
And for folks who want to see what a framework around social determinants of health are, could you walk us through this?
Sure. So social determinants of health are the conditions that influence health outcomes like life expectancy or health status or like functional limitations outside of just general health behaviors and genetics. Aging and community efforts typically revolve around addressing those social determinants of health, including income and medical bills, food, community and social context, and the health system, among many other determinants you see there on that slide here of the selected social determinants of health. It means helping seniors with activities of daily living like bathing and cooking, and then those instrumental activities of daily living like grocery shopping and managing finances. For example, access to healthy foods has a clear impact on health, but seniors may have trouble preparing the actual food because of how their kitchen is set. So the intervention there is not increasing healthy foods, but rehabbing their kitchen to have tools, appliances, and furniture adapted to their level of mobility. And often the entry point for aging and community programs is through housing. It could be an affordable housing developer providing a bunch of services to its residents, like we'll see with AHC Greater Baltimore, or a fully integrated system like STASH and Downstreet Housing and Community Development.
And as we think about program integration, could you walk folks through what that means to really integrate?
Of course. So the idea is that no one organization can fully provide all aging and community efforts, all those social determinants of health. So it's a conglomeration of partnerships. And so how integrated are those partnerships? A fully integrated system will set up data sharing and common outcomes, coordinate decision-making and planning efforts, and braid funding so that health, housing, and community development dollars are not siloed. An integrated program makes it easier to provide that customized patient care and makes partnerships that much more productive for everyone involved.
And you mentioned funding. Can you walk folks through sort of funding and how you might think about that?
Yes. So the landscape is very diverse. Eligibility pools and funding and partner orgs vary depending on where you are and also maybe in what fiscal year you're in. And aging and community efforts typically means leveraging housing and community development dollars with those health dollars. And many, if not all of the programs I've studied received a significant portion from foundations, the idea being that you fund that pilot study to be able to show results and outcomes and then attract more sustainable funding sources. But there are still a few examples of funding players and partners here on this slide that will hopefully give you an idea of what can be and has been done in the aging and community space. So first is Medicare and Medicaid, which may cover some aging and community services like home visits. I found benefitscheckup.org helpful in determining eligibility rules by your state and even county. Next is a managed care organization, or MCO. That's a delivery model where insurers aim to reduce costs and increase health outcomes by receiving a set amount of funds per patient. And then also an ACO, or accountable care organization, where a group of doctors or healthcare providers get together to coordinate care by taking on some of that risk and turn it into sharing cost savings, just a few payment delivery models. And nonprofit hospitals also play a role. So they have community health needs assessment, which are they're required to conduct at least once every 3 years. And it includes an assessment of and implementation plan for increasing community health outcomes.
Great. So I think to unpack some of this, we're going to be talking about a few examples where there have been partnerships around, either Medicare, Medicaid, managed care organizations, accountable care organizations, and hospitals. Mm-hmm. So let's start with talking a little bit about hospitals and community health needs assessment.
So first, on how to get involved in that, hospitals are required to engage with the community, and that means anything from reaching out to stakeholder groups to holding public forums. Some hospitals have advisory boards. Some NeighborWorks organizations have actually served on those community advisory boards. And also the hospitals are required to post their reports publicly, so you can go online to your local nonprofit hospitals and see when the last report was and how they're, the strategies they're using and the populations they're serving, and that way, from there, you can see how you can reach out to begin a potential partnership. And one great example of that is NeighborWorks in Western Vermont. So they partnered with a local hospital, Rutland Regional Medical Center. Through the community health needs assessment, they identified the issue of a healthy home rehabilitation program. So the program identifies, funds, and implements doctor-prescribed home improvements, the goal being eventually to make the case to Medicaid to fund them. Right now, they're being funded through the Rutland Trust from a $75,000 grant and NeighborWorks. So far, 30 homes have been assessed, and NeighborWorks has funded 5 remediations.
Yeah, and also they have been incorporating community development block grant and other funds in this process. Mm-hmm. Home rehab is definitely a big component of many aging and community programs. Can you walk us through sort of another example in a rental setting?
Sure. So a great one is Kippick's Place. It's an affordable housing development for seniors run by community housing partners in Hopewell, Virginia. Kippick's, originally using county health rankings and roadmaps data, saw that a lot of health disparities existed in Hopewell, so they were behind national averages in many health indicators and outcomes. And NeighborWorks is finalizing an in-depth case study of their whole aging and community project in Kippick's Place, so look out for that, which will be available in the next few months. But I want to go through the highlights of the program model and its implementation.
Sure, and the case study will walk us through, but let's give it a little teaser. How does CHP set up this program?
Sure. So CHP first partnered with Controlled Outcomes, a local nonprofit, to implement both lifestyle changes to healthy food programming, nutrition education, and health interventions, so that comprehensive patient-centered care management through a partnership with a local for-profit hospital, John Randolph. It was the only hospital in the area, to build a program that reduces hospital readmissions. The Center for Medicare and Medicaid Services Hospital Readmission Reduction Program incentivizes such programs. So CHP and Controlled Outcomes were able to make a business case for the partnership, and I'll go into that in a few slides. But also with Controlled Outcomes, CHP implemented a collaborative care model. You can see they're leveraging both a Memphis model, which draws on the well-established communities among clergy and congregations to provide that support to those who are religious, and then the Camden model, which targets frequent flyers of the healthcare system and works backwards to identify whether there's a support system that wasn't as supportive as it could be, or new support systems to put in place.
Fantastic. And interestingly, the Camden model, there's an effort with St. Joseph's Carpenter Center, another NeighborWorks organization, with the Camden model. But for folks who are not necessarily frequent flyer terms, might folks want to know a little bit more about what that means?
Yes.
Would you mind defining it?
Yep. So a frequent flyer, sometimes also called a super user, is an individual who relies heavily on healthcare services. It could mean that their transition from a hospitalization back home did not come with adequate supports, like we were talking about, like follow-up visits or adequate aids. And this is something that CHP identified as an issue and worked with controlled outcomes to address. So under the new program, everyone involved, not just the hospital, receives a copy of the patient's discharge plan, and then controlled outcomes puts together a coordinated transition with a combination of nurses, nursing assistants, medication aides, which is huge, and care aides that support that transition back home.
Right. And if anybody who knows me is not going to be surprised that my next question is about outcomes. What were the results?
We got some good numbers. So 64% of residents were participating in one or more program components as of 2017. This is a year of outcomes. There was a 29% decrease in hospital readmissions, that's within 30 days going back to the hospital, a 61% decrease in emergency department visits, and a 35% decrease in 911 calls.
Fantastic. And that's this theme of reductions in emergency department visits or emergency department usage is something we saw in the NeighborWorks Healthy Communities demonstration project across a lot of organizations, which was a partnership with the Robert Wood Johnson Foundation and the County Health Rankings and Roadmap program. But for folks who like a good story, rather than just the numbers, what does it feel like on the ground? After all, if the residents don't feel like they're benefiting, then why are we doing this?
Right. So I mentioned before how Hopewell was behind a lot of the national averages, and they really felt like a forgotten community. Residents reported they no longer felt that way. So they were engaged more with the programming staff, and the program staff and the volunteers involved also reported deeper levels of trust with the residents. So which it all allows for better programming and then just higher well-being for the community at large. It was more connected, people were more open to sharing feedback, et cetera.
And one of the things is, and this comes across many different situations, is that setting this up wasn't linear.
No.
So, roadblocks. Tell me about that.
Sure. So the first thing I mentioned before about that business case to a for-profit hospital, whereas a nonprofit hospital is required to look at the community and assess what can be done, a for-profit hospital is maybe a harder nut to crack. So originally, the CHP came to them and focused on the prospect of fewer charity write-offs. The idea being that if they reduce, if they increase health outcomes, there'll be fewer sick people who could not pay for their own care. But that kind of received a lukewarm response from the hospital. To kind of get that better angle and get them more excited about the partnership, they reached out to someone on the board to identify that internal champion. And they discussed about that hospital readmission program, which is the hospitals receive a penalty for readmission. So it was more concrete of reducing costs and helping the hospital. So they were able to make that business case and make that partnership all the more stronger from identifying aligning missions and aligning outcomes.
And folks on the line suggested we talk a little bit more slowly. For some reason, we have a New England contingent and talking way too fast. So we'll try to work on that. And thank you for the feedback. Okay, now I have to figure out where we are.
Next is gaining access to valuable data.
Yes.
So originally, CHP went to the hospital for that frequent flyer data we were talking about, the super users. And when they ran into roadblocks there with communication, they switched gears. And I think the line in the case study is, when one door closes, find another door. So they went to the fire department after realizing that the vast majority, 98% of the residents' emergency room visits came through them, and they got the data that way. So it's all about kind of, if data isn't accessible one place, it doesn't mean that it's not available to you in another. And finally, strong partnerships. So controlled outcomes was very well connected within the community. They knew a lot about local regulations. They were involved with a local council. So partnering strategically that way helped them. So they were connected to more expertise and more resources.
Right, and I think you've shared a lot about how this effort really tried to be sort of center its work around the patient and around the local organization. Can you share more about what you're seeing in terms of emerging trends or models?
Yes. So technology tools are an interesting aspect of aging and community, and particularly telehealth. A great example is Avesta Housing. It's an affordable housing provider in Maine. They sought to use telehealth as a way to offer care in the housing property, and this is particularly useful in rural areas like Maine. Avesta received a $400,000 grant from the USDA's Distance Learning and Telemedicine Program, which provided the necessary HIPAA-compliant technology to set up that private telemedicine room that's required. Avesta made the services available at 2 senior properties through partnerships with a local hospital, York Hospital, and a hospital system, Maine Health. So after engaging residents to see how exactly they may want to use this service, Avesta and its partners decided on an urgent care model. So residents wanted to keep their doctors. So Avesta developed that service as something that kind of bridges that gap between a regular doctor appointment and an emergency room visit, something you might go to an urgent care if it wasn't urgent. And in the first 10 months of the program, 86 new residents were seen, plus 27 repeat visits. And some more outcomes on that. You can see here that residents were using the telehealth program for general questions, wellness visits, and vaccines mostly. And of those 113 total visits, 20 recommended a follow-up with the primary care doctor. So the program helps to refer those who need additional care, but helps prevent that unnecessary visits that the remaining 83 could have turned into.
And just, I think Annabelle said the term, but PCP stands for primary care provider.
Yes.
So. Okay, fantastic. Now, challenges here too, right,
yep.
Annabelle?
Yep, especially with technology. So in Maine, there was funding for the equipment through USDA, but not for the actual visits. Maine's Medicare Part B covers certain telehealth services, but it can depend on your exact location and where you're providing it. That has meant lower use than expected from Avesta of the services, but this is certainly a policy issue that can be addressed. So you may be able to change the eligibility rules by advocating at the state level, which has been successful in other states to get that covered. The property also described issues with getting seniors comfortable with using the technology. They do offer demonstrations, and they're currently looking for new ways to engage residents. Other programs have found more success with having a nurse or a health professional in the same room and kind of act as that ambassador to guide them through that telehealth visit. And also, in my research, I've seen success with using resident leaders who champion new technology. So often seeing your peers do something makes you more able to imagine doing it yourself. And of course, technology is only one part of the healthcare services it offers. It's certainly a useful tool, but not the only one available.
Yeah, resident leadership is never going to be poorly received in NeighborWorks America. So, okay, lots of examples, but what are you seeing across the board?
Sure. So here are a few lessons learned from my research and also talking from practitioners in the field. So the first is understanding residents' needs at the granular level. It's not only if someone is dealing with a chronic condition, but what are those specific barriers they face and challenges they have in treating that condition or managing it. It doesn't mean understanding every single thing, but understanding maybe 2 or 3 issues with some specificity so you can discuss that with a health partner and begin solving it. The next comes from the conversations with experts in the aging and community field. After identifying those issues, it's tempting to want to solve everything in-house, but you and the residents may be better served by engaging a partner who has more experience, more connections in that issue area. That way you can continue spending time on your core competencies and mission, and those valuable partners can address your residents' needs with a more focused perspective. Going back to that CHP example with controlled outcomes, they had experience both in the community and with health outcomes, so bringing them in was more strategic than doing it themselves. Finally, or next is tracking and communicating outcomes, which is crucial to understanding any program. Different funders are interested in different outcomes, so taking the time to understand those interests will pay off in the long run. And finally, successful programs are future-proof. So they take preventative measures like ensuring new housing units are designed with seniors in mind, with universal design. Incorporating age-friendly policies and models early in any community planning process will result in positive returns down the road. And before I turn the mic back to Allison, I wanted to give you all my email address for any questions or suggestions. Is there a topic within the aging and community space that you'd like more information or context on? I can't promise to know how to find all the answers to everything, but at the very least, I can offer NeighborWorks ideas on issues to convene people together and solve. And finally, some acknowledgments to the practitioners and experts who have kindly shared their experiences and perspectives, along with the sources for the info presented in this slide. Thank you, and back to Allison.
Thanks, Annabelle. Next up, we have Eileen Peltier. She is the Executive Director of Downstreet Housing and Community Development, and she's going to talk about a very innovative health and housing initiative that they launched 9 years ago called Support and Services at Home, which is now a statewide program in Vermont and has been modeled for national replication. Eileen?
Kind of a brief overview of the SASH program that, as Allison said, has been around since 2009. In 2011, we were able to expand the program through funding through the Center for Medicare and Medicaid Innovation. So it's actually funded through Medicare to a statewide program. And over a few years after that, we've grown to 5,000 participants, of which 68% are women. They range in age from 22 to 101, so we serve both Medicare, seniors, and young disabled. The average age is 72, and we cover every single county in Vermont with our program. And I think, you know, the thing I want to say most about the SASH program is what you can see in these pictures is happy participants. So looking at this next slide, this gives you a colorful depiction of Vermont. It's not fall foliage season, I assure you, yet, but it's very green up here. And we have a collaboration that we're actually very proud of with this program. It involves 6 different housing organizations, 4 of which are community development corporations, and 2 of which are public housing authorities. And our roles, each of us, you can see, has a portion of the state. The little yellow dots are where there are actually housing sites that are participating in the program. And we are each a designated regional housing organization. We coordinate the programs for all of the counties within our area.
That's fantastic. It's wonderful when public housing and nonprofit housing are working together.
So I think this slide we'll spend a minute on. So SASH on the ground. So this is a slide that kind of tells you what we're actually doing with the participants. The most important thing to know is that the program is completely voluntary. We offer it within our housing settings, which are both senior housing settings and multifamily. So there is offered to everyone regardless of whether they are Medicare eligible. Mainly a decision that most of the housing organizations made just because they wanted to offer consistent services. So 75% of the people live in the congregate housing setting, and because we're a rural state, we also offer it to about 1 in 4 people are within the community, and they most typically connect with us through the senior centers in the communities. So we also have a no discharge policy, which is an important one. So SASH on the ground, basically what we want to explain about this program is there is a partnership between a SASH coordinator who sees a panel of 100 people and a wellness nurse who provides anywhere from 10 to 20 hours a week of support depending on how the funding was structured in this particular panel. In the middle of this, you see the participant with their fists up in the air saying, "I've got this, I'm in charge." This is a patient-centered program. Important to know about our programming, and we think one of the reasons that we've had the outcomes we've had is because we've taken the lead. We haven't, from the participant, we haven't layered over, here you need to do a program to address your diabetes. We've let them kind of drive what they want to work on. So in addition to that team, on the next slide, we have statewide partnerships. And so in addition to the SASH coordinator and the wellness nurse who are actually on the staff of the housing organization, so they're part of my team here at Downstreet or across any of the other 22 housing organizations participating in this across Vermont. So in addition to those players, we have partnerships with the local area agency on aging, the mental health agencies, the visiting nursing association, the hospitals, primary care physicians, and we have a memorandum of understanding that allows us all to collaborate together to work on care plans for our participants. So, and that is on a platform which is a statewide, essentially electronic medical record that essentially has a hard wall and allows us to see what we need to see to run this type of program without seeing, additional HIPAA type information that we don't need access to. So we have a really strong statewide partnership, and we actually call SASH, it's called SASH a caring partnership.
Wonderful. And I think folks will want to know about the outcomes.
Right. So to me, you might have gotten this from me at the beginning, the most important outcome, although not the one that, gets it funded, but the most important outcome is what you see here. And these are just some samples of comments from SASH participants. It has been one of the funnest programs we've ever run. And just a really, really brief story, one of our residents who has been with us since we opened our first multifamily housing property 30 years ago, spent 10 years in not really able to leave her apartment. Our maintenance manager would stop in and check on her 3 or 4 times a week. And with SASH, working with her for the past several years, she actually came to our annual meeting last year, which was a great treat. So lots of really positive experience for the residents.
And now for the data.
Yeah, so this is just a sample of the data. Because we have this electronic medical record, we collect a lot of data. This is some of the stuff that we have been looking at, like whether it's different types of vaccinations or advanced directives, falling, ER visits, controlled hypertension. We're able to track it all, and I think that's one of the really good things about SASH and why it's had so much success, is because we've had really good data going in and really good data coming out because of the work we've done. Because at the end of the day, that's what Medicare or other potential funders need to continue to fund it for the long term.
And Eileen, there was a question earlier from somebody listening, and so I'm just going to throw it in now, although it's late. You said that there's a no discharge policy. Would you mind explaining what that means from SASH's perspective?
Sure. So that's that's a bit of a medical term. So if you are in a nursing home, you can be discharged. Most nursing homes, in other words, you can be asked to leave the nursing home. Assisted living, the laws require that you can't leave. But we think it's important to note that our real goal here is that people age in place. And that they hopefully are able to do that through the term of their life with the level of support that we're able to provide, whether that may even include including some connection with hospice care, which we have certainly done at times. So
that's fantastic. And I know you guys are thinking, so I'm just transitioning, sorry, from health outcomes.
Right. So health outcomes. Yeah, let's talk money. So there have been, one of the things we did well, I think, with this program is tracking the data, but we used some outside practitioners to do that. So it was an objective view on the outcomes. And what we were able to see is that there were significant Medicare savings. So savings of $1,227 per person per year. And when you multiply that by 5,000 participants, that's quite a lot of money. And that certainly has led to us being at a place now where we are consistently funded through our all-payer model program in Medicare, and we are no longer calling ourselves a pilot. It's just an ongoing program. So that was an exciting moment because that only happened, I think, a year and a half ago. So 7.5 years in, we finally feel like we're funded for good, and largely related to the savings that we've been able to achieve.
That's amazing, Eileen. I am so excited. So one of the things that's come up increasingly in conversations is around sort of mental health and well-being. And so I wanted you to share a little bit about how you're thinking about going more deeply into that space.
Right. So as I mentioned earlier, one of our core partners has always been the mental health designated agency in our community. We knew mental health was a challenge very early on. The first 100 participants, 40% of them self-reported depression, which is huge. So we knew we needed to do something with that, but we eventually realized as we were operating the program that we would really benefit from an elder care clinician working as part of that core team, right, with the SASH coordinator and the wellness nurse. So we are piloting that right now in Chittenden County, which is where Burlington is the largest area in the state. And from what we're hearing, we don't have any definitive data at this point, but from what we're hearing, it's been very successful. And if it goes well, we expect that funding for this will be expanded across the state. And I think, you know, it's a really important part of the mix. And if you ask all of us who have been doing this SASH thing for a decade, what's the thing that matters most about everything we do, about the programming we do or the tracking we do, we would all say it's social connectedness. Absolutely all about getting people together. So, you know, to those of you thinking about doing it, you know, starting small and getting people in a room together to do some chai tea or bake some cookies, it makes a huge difference knowing that mental health is a big part of what people are struggling with.
Yeah, and I think the other thing that's really interesting is that if you're focused in on diabetes prevention and self-management, and also a partnership with a pharmacy, which is not the most common partnership model that we were seeing. So I'd love to hear what you're doing in this space.
Right. So I think, you know, part of what's happened with SASH is that there's just been quite a lot of press and positive feelings about it. And so this idea of including a pharmacist on the SASH team was something that came from the community, from the pharmacy. There was a real interest in saying, you know, I think that we can work together and do better than what a physician's able to do, you know, when they have a visit every 3 months for 15 minutes. The pharmacies, you know, are really working in the community like we all are, and they saw a connection there. And so right now we are piloting this in Rutland County in Vermont. And again, you know, if you look at healthcare dollars, one of the biggest things that is rising fast within insurance costs is related to the cost of pharmaceuticals. So if we can help with that as well, it's only going to help the outcomes to the people we're trying to serve, to our participants, but the overall cost to, you know, the community and all of us related to the cost of healthcare. So excited to try this one out and see what it does.
And I realized we started to say hemoglobin A1C4 because we wanted to define it for our listeners, and we left it blank. So that's probably the one term up there that people might not know. So if you want to share why hemoglobin A1C is so important.
Well, I'm not a clinical practitioner, but I know it has something to do with diabetes prevention. Yeah, so that is, just to make a point though, you know, I think Sarah will mention it later. There's a lot of terminology here. I was fortunate enough to work in the healthcare industry for 20 years before getting into affordable housing, so I'm not afraid of it. But just remember what it was like when all of you started working in affordable housing and you didn't know what any of the abbreviations meant. It's sort of the same thing here, and there's actually a great glossary that NeighborWorks has done to help you through some of that. So.
And not everybody needs to know what hemoglobin A1C is.
Exactly, including me.
Right. So, with that, I will we'll turn it over to Allison and Latrice.
Thanks, Eileen. As long as your health partners know, right? That's the important part.
Exactly.
So now we're going to turn it over to Latrice Good. She's a resident services manager at Monte Verde, which is a community of AHC Greater Baltimore. It's one of our senior properties. And I've had the pleasure of working with Latrice for over 7 years now. So thank you so much for joining us, Latrice.
Thank you, Allison. AHC Greater Baltimore is an extension of ACE, a developer of affordable housing located in Virginia. AHC Greater Baltimore has developed 8 properties in the Baltimore area. The community we're discussing today is Monte Verde Apartments. Monte Verde consists of 301 affordable 1- and 2-bedroom apartments for seniors and non-elderly disabled. Monte Verde has its own shuttle and public transportation picks up on site. In 2010, we completed a $30 million renovation to upgrade the apartment homes, common areas, and grounds.
That's great. And So I have the privilege of knowing all of the exciting health programming going on at Monte Verde, but would you mind sharing some of the efforts that you've been doing to help seniors age in place there?
Sure. In 2017, I attended a health convening at the NeighborWorks Institute where I learned about the SASH program, and I was really inspired and wanted to bring something like it to Monte Verde. So in February of 2018, we began a partnership with a local health provider called TSC, Healthcare Services. The engagement started with visits by a nurse. Because she visited with the residents in their comfort zone, it allowed her to identify trip hazards and make health suggestions to the residents that they were more likely to adhere to. She works in conjunction with their primary care doctors and other health professionals they're seeing, and the visits are covered under Medicaid and Medicare as a doctor's visit. And I have an example. A senior male resident, he was drinking Pepsis. He has diabetes. So the nurse practitioner was able to convince him to drink Diet Pepsis, and she also was able to coach him to make a little more healthy food choices. So eventually he came, he did what she suggested, and he came into resident services bragging that his blood sugar levels were lowered. So that was a plus. Then recently, the FDA had a call on a popular hypertension medication, and one of our senior female residents called the nurse practitioner to find out how it would affect her, or if it affected her at all. And so the nurse practitioner was able to tell her that it didn't affect her medication at all. But if she was to contact a primary care doctor, it probably would have taken hours, if not days, for that primary care doctor to give her a call back, where with the nurse practitioner, she was able to get her immediately. So in the beginning of us bringing TSC Healthcare Services to Monte Verde, we, of course, looked for outcomes. So we piloted the program with 18 residents. We surveyed the 18 residents to determine their health and health needs before and after receiving care from TSC. The majority reported that their health improved, and the rest reported that their health remained the same. Some other exciting data that we're continuing to track is emergency room visits. We've seen a reduction in visits for residents in the group, and we'll continue to track that and look back again in a year to see if the trends continue.
Thank you. This is a great program, and I'm so excited you could share these preliminary results. What other health issues are you guys working on at Monte Verde?
We have healthy food access. We know that food can directly affect your health. So we have the Maryland Food Bank, which has a My Groceries to Go program. That program delivers a box of groceries to the residents once a month. We also have a partnership with Hungry Harvest, the Harvey Harvest program. And so what that program does, it allows the residents to purchase fresh fruit and vegetables at an extremely low cost. In addition to, we have a partnership with one of the community churches. So once a month, they host a produce drop where the residents can go and get free produce.
Awesome. And so is there anything we can do to help them know a little bit more about what they do with this food that we give them?
Yep, absolutely. So we have a healthy food preparation partnership as well. Crystal Foreman of Holistic Wealth and Wellness, Wellness and Health. Sorry guys, I got a little tongue-tied. Performs healthy cooking demonstrations at Monte Verde based off of the food the residents receive. She corrects misconceptions that eating healthier is expensive. She also offers residents a different twist on some of their favorite foods. For example, a number of residents were boiling the nutritional value out of the kale, where Crystal demonstrated a crispy kale dish for them, which they found tasty, and it didn't compromise the kale's nutritional value.
That's great. So I'm going to switch gears a little bit. I know that substance use disorder, which does come up in these conversations more and more lately, it's a prevalent issue among seniors, and I know some seniors at Monte Verde as well. Can you talk through a new program that Monte Verde is piloting to help residents address that?
Yeah. It's a program with the Turk House. unfortunately, some of the residents have struggled and continue to struggle with substance abuse issues. In our efforts to provide them with substance abuse resources, we found that Medicaid eligible residents could access treatment faster and more often than residents with Medicare. In addition to some of our residents would rather admit to mental health concerns than substance abuse. So in our effort to combat at least the insurance challenge, we reached out to the House, one of the oldest and more successful substance abuse programs in the city. We did this back in 2016 to learn if there was a way they could offer care to our Medicare residents too. After years of collaboration, and once the House found a way, after years of collaboration, and once House found a way on the business side to make it work through their own financial partnership, on August 6th of this year, they were able to offer coverage to our Medicare residents. So it took years of research, trial and error, but we're still very optimistic about what this kind of program can do for our residents.
That's awesome. We did have a question that came across. I'm wondering if we could jump back just a little bit to ask you a question about the nurse practitioner program.
Sure.
That's okay. I don't want to put you on the spot here, but somebody did type in that and is curious if the nurse practitioner had any specific training, to your knowledge, you may not know this, to help her identify hazards in the home, or is that?
Yeah, so she was actually a professor of nursing at the community college for the last 20 years. And what happened with her is her grandmother became ill, who she's very close with, and she was having a really hard time finding services and different things for her grandmother to be able to age in place. And so from her own personal experience and her professional knowledge, she's able to identify trip hazards, which could be something as simple as maybe you plug the lamp up and run the cord across the floor to the other outlet.
I have seen that.
Yes, for a senior, that could be very dangerous. That's a trip hazard.
Mm-hmm. Absolutely.
I've also seen some like occupational therapist associations have quick checklists to see trip hazards and smaller training modules for maybe not professionals, so people want to maybe start identifying those themselves.
Mm-hmm. Very helpful. Thank you, Latrice. I'm going to turn it back over to Sarah now, who's going to take us into the Q&A. But
yeah. That's right. Get ready to submit your questions in the Q&A box or in the Zoom chat. We will respond that way. And I did want to run through just a few resources that are available, mostly through NeighborWorks, but also elsewhere around aging and community. There are a few courses that may be relevant that are offered regularly at the NeighborWorks Training Institute. The first is the Silver Tsunami, which is Housing Seniors in Our Communities, AH 150. Health and Housing, Connecting to the Healthcare System for New Partnerships, New Opportunities. That is designed to serve all populations, but Eileen here is a teacher, along with Nancy Eldridge, who the two of them really helped develop SASH, and so their knowledge in the area of senior health and housing is clearly incredibly deep. So if you're thinking about designing a strategy in this space, the course is designed to help you unpack some of the financing a little bit more, some of the outcomes a little bit more, the partnerships, and then sort of think through an action plan for your community. Universal Design and Visibility in Affordable Housing, CP 265. The Essential Tools of Successful Neighborhood Revitalization, which addresses sort of thinking about age-friendly communities. Senior Services for Housing Counselors, HO 270 is another option. And then some of the terms that came up really were focusing on financing, et cetera. You might be able to look at some webinars which are available whenever you want online. So for example, if you want to get deeper into financing, we do have a Healthcare Financing 101, which could be helpful if you're thinking about a community strategy or if you're trying to unpack some challenging specific situation that applies to a specific senior in your life. Also, yes, glossary of terms. We have a glossary which is available online. There's a health subpage of NeighborWorks, and you can find the glossary there. Build Healthy Places Network also has a jargon buster, which I think is very cleverly titled. And while I'm sort of wrapping up, think about your questions or comments, or we also welcome, something really neat that you're doing in your community or a challenge that we want to talk through. This is designed to be as interactive as a webinar can be. So that's it from us. And for folks who have questions, we'll turn to the chat or the Q&A. While we're waiting for questions, I thought I could ask Eileen a question. So I'm just curious, as you sort of think about moving forward with SACH, I know one of the things that's come up is this question about what does this mean as an affordable housing provider? And does this actually help you from the, it's all well and good for resident services where, resident services staff definitely are generally committed to these, but how do you make that case to other folks within your organization that thinking about approaches like SACH are worth it and can be done?
Well, it's interesting. It's been a process for our organization to get there. I think that our property management staff, really our entire staff, understood really early on that there was a ton of value to a program like this. And, you heard me mention earlier on that my maintenance manager was the one visiting the elderly woman who had been in our housing for 30 years. So we as people care about each other and we want to do that work. And so the first thing I'll say is that we have not quantified this yet, but we do firmly believe within our organization that the cost of the SACH program, a fair amount of it is covered by less staffing needed in our property management department. So basically it's like the preventive approach. If you're able to work with an individual through the SACH program, address some of their needs, you're less likely to have turnovers, you're less likely to have, challenges, even if there's, minor budget issues or confusion happening. Those are all things that property management ends up dealing with. So from a kind of asset management perspective, we have felt since we started it that it just made a lot of sense. But then in a more sort of strategic, I guess the fear might be mission creep. And I think the reality is, yes, I think our mission has crept, and I think that it has been exactly what we should have been doing all along, or maybe even we formalized what we've always done. We had a strategic planning process last year, and there was an aha moment when one of the board members just looked at everyone and said, 4 walls and a roof just isn't enough anymore. And everybody looked at each other like, yes, you're absolutely right. We build great housing. We're proud of what we do. We run a great property management department with the heart and proud of that, but it's not enough. And so the line that we've drawn in this is that we are the organization that is, I don't know if people are familiar with this term, but kind of the integrator. So we're not in the business of hiring nurses or medical professionals, but we're making those connections, right? We're bringing all those partners together. So a lot of our strategic plan is around developing those strong partnerships to get the work done. And it's a great way to honestly lift up all our community organizations who are trying to serve so many people. And I think that is one of the things that, even though it was hard at the beginning to get partners on board, it's one of the things that I think we're most proud of, that we stuck with that approach and we didn't just give up and say, all right, we'll just do it ourselves. Because, there's a lot of good programming out there and we can make that connection. And as long as we stay in that box for the most part, I feel like our board and our supporters get what we're trying to do.
Fantastic. And I have one question about this PowerPoint. The PowerPoint and the recording will be made available, so you can share this with other colleagues. And we also had a follow-up question for you, Eileen. How does resident services at the housing communities work with the coordinator and the wellness nurse, such as SACH? How is that sort of integrated and coordinated?
Right. So it's different in different areas. So my organization is Community Development Corporation. We have not had resident services funds ever. So it wasn't an issue, but as I mentioned earlier, 2 of the groups that are part of the core groups, and well, basically all public housing authorities within the state of Vermont, all 10 of them participate, and they do have resident services dollars that they have had for many years. They have much more experiences in this sort of area of resident services. So for them, originally they were kind of kept separate. People were a little hesitant. So the early panels, people didn't really kind of understand how this was going to work, and resident services is different than care management. Now they're fully integrated. So they just actually get a little more density in the staffing, a little bit more capacity to do more programming, and it's worked out really well. But I would say all the public housing groups at this point have really fully integrated resident services and the SASH coordinator. The whole program has kind of come together under one umbrella.
Fantastic. And I know Annabelle has a question.
Yes. So going back to when I was talking about social determinants of health, something else that's big in the aging community space is also age-friendly banking or financial capability. So there's the program making things cost less or changing the Medicare and Medicaid eligibility rules. And then there's also supporting residents to help them finance things. So there's kind of going at from 2 angles. And I know HC of Greater Baltimore has a great financial capability program. Do you want to briefly touch on that and how that helps?
I can. This is Allison. I'd be speaking more for our service managers in the field working directly with the residents than myself, but I can say that, our residents are all, with few exceptions, extremely low income. And so any changes in the healthcare field that impact their bottom line or their budgets are going to be felt, dramatically by them. And anything that we can do to help them increase their income or decrease their expenses are going to be a way that we can help them stay healthier. It's a direct correlation. So we work with them to help them, connect them with banks that are friendly to them, that are low fees, that have products that are good for them. We help them use those products online so that it's more accessible for them. Using, especially at our senior property where we have a shuttle, we can actually make monthly bank runs to facilitate that. And then we also just help them with their budget and through financial coaching. And it really is important that it's financial coaching and not just counseling, where we can feel comfortable and help them feel comfortable sharing with us what the issues they're experiencing, and that they can feel open and comfortable in talking with us about their needs.
And I know when Latrice and I were talking about the programs, one of the things with the Turk House, with the mental health and substance abuse disorder programming, is that people were worried about leaving their homes for a long period of time because they might not pay rent or something. So yeah,
one of the barriers we thought, but we had a program where they can pay their rent online, like automatically. It goes directly to the management company, and so their rent's paid, and that's not a concern. And as Allison was saying, we also look for programs that can save them money, like QMB or SlimB, or so any way that we can bring programming and resources to them to help them decrease their expenses, we do. Yeah.
Well, fantastic. I'm actually going to give one last call for questions. There's, if it's okay if we end 5 minutes early, give people 5 minutes back to their day. But I do want to give one last call in case folks on the line. But I think we've answered all the questions there ever were. Where could we find the link to the webinars? Let me see. It will be, so if you go to NeighborWorks, there's a subset that says community. And then if you go under that, it says health, and there's lots of webinars there. We'll also send out an email saying thanks for registering, and here's where you can see it. But that's a very important question. Anybody, I'm going to give 15 more seconds for questions, and then give people 5 minutes back into your day.
Also searching for the webinars on YouTube. That's how I always go. I just search NeighborWorks, and on YouTube
NeighborWorks webinars. Yeah. Oh, hey, I didn't know that. And then you can rate comments on YouTube.
Throw us some likes. Yeah.
Okay, well, oh, where can we find the links to the webinars? I tried to answer that verbally. I will respond here. So I responded on there. So great, thanks so much for everyone, to everyone. Fantastic. Have a wonderful day. Thanks, Irene.
Have a great day.
And everybody in the room.
Thanks, everyone.
Bye.
Bye.
Bye.